in Louisville, Kentucky, and I'm currently finishing my Ph.D. of nursing at the University of Louisville. And then during that time in my studies, I began to specialize in pressure volume loops and mechanical circulatory support. And then I recently began a new position at Abiomed as lead of scientific communication. So, as he alluded to, today's discussion will be looking at some cardioprotective aspects to cardiogenic shock and LV distension. I use the Harvey, in my presentation, I use the Harvey program developed by Dr. Dickstein and Dr. Burkhoff. I chose to record my sessions, so they're going to share that here in a minute, because in my experience, when I share it through these platforms, sometimes the loops lag a little bit, so it doesn't come through as clearly. So in the recorded version, it kind of bypasses that issue. So I'll be here after to answer questions, but thank you. So for this presentation, we'll be looking at a conceptual exercise of LV distension on ECMO, looking at afterload sensitivity and energetic efficiency. So some of the objectives of this discussion: we want to conceptualize cardiogenic shock and LV distension through pressure volume loop analysis. We want to compare and contrast the hemodynamic and energetic effects of an acutely failing heart and the added effects of VA ECMO. And we want to demonstrate an understanding of unloading left ventricular workload. So for this discussion, we're going to take a mechanistic view of the heart. So this is going to be viewing the heart as a muscular pump that generates power within the cardiovascular system, sending that energy out to the cardiovascular system and to our end organs. So there's a few concepts here that we're not going to dive into great detail, but for power, we need oxygen, energy, and work. And so oxygen is required for energy production in an aerobically dependent organ like the heart, and work is just going to be that transfer or transformation of energy from the heart to the cardiovascular system. And we're going to look at power here in a second, but it's just the rate of work being done. And so clinically, power is very significant. When we're looking at a single heartbeat, such as a still shot of a pressure volume loop, ventricular stroke work is going to be more useful to look at. So defining ventricular stroke work here, it's the work performed each beat. Often it's derived from mean arterial pressure times stroke volume, and that provides a nice approximation of ventricular stroke work. Now, to get a more accurate estimation of ventricular stroke work, we want to look at the area within the pressure volume loop. And then for power, so it's going to be a very similar formula for mean arterial pressure times stroke volume, but again, power has that rate aspect. So that again, clinically, that's going to be heart rate. So it's just going to be mean arterial pressure times stroke volume times heart rate, or mean arterial pressure times cardiac output. So that's ventricular stroke work and ventricular power. As we discussed, ventricular stroke work is going to be more accurate, looking at the area within the pressure volume loop. And so here in just a moment, we're going to look at pressure volume loops and discuss that a little further. But first, looking at why we want to view the heart in this manner. So taking this mechanistic view of the heart allows us to view cardiogenic shock. It allows us to view the heart as a pump, and then it allows us to view cardiogenic shock as pump failure. So cardiogenic shock is that weakened and failing pump where we have insufficient cardiac output, we've got increased afterload sensitivity, elevated filling pressures, and impaired organ perfusion. And so a caveat to this whole conversation is recognize that there are many phenotypes and different degrees of severity of cardiogenic shock. So for instance, we could have acute myocardial infarction cardiogenic shock, we could have acute on chronic decompensated heart failure, we could have right ventricular failure, biventricular failure, or isolated left ventricular failure. So recognize that throughout this conversation, but for the purpose of this conceptual exercise, we're going to be looking at more of an acute myocardial infarction, isolated left ventricular type of cardiogenic shock. And again, cardiogenic shock is going to vary on degree of severity. And one point we're going to talk about a lot is afterload sensitivity. And understanding that point is going to help us understand where our patients may fall along this severity continuum, and when that might, in the case of VA ECMO, when that might result in LV distension. So more to come on that as we talk about can progress through our conversation. First, I'm going to give a high-level overview of pressure volume loops. So if you see in this diagram here, we have a single left ventricular beat. And so to start off, we have 4 valvular events labeled A, B, C, and D. So you can think of those as the 4 corners. And again, each of those 4 corners are going to be a valvular event. Next, we have 4 phases. So usually we have the 2 phases of systole and diastole. Pressure volume loops do a great job of breaking that down further into 4 phases delineated by these valvular events. So we have the isovolumetric contraction phase, the ejection phase, the isovolumetric relaxation phase, and then the filling phase. So starting down here at D, we have the opening of the mitral valve, and then we have the filling of that left ventricle as we go along the x-axis here, which is volume, and the y-axis is pressure. So during this filling phase, we are filling, 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 until we get to A here, which is the closure of that mitral valve. Now we have the beginning of contraction. So those myocardial tissues are beginning to squeeze and contract down, and we get this large increase in pressure. So this is the isovolumetric contraction phase, iso being same, volume being same. So during this phase, as you notice, we do not change volume, we just change in pressure. It's because we have a closed chamber here. So A is the closure of the mitral valve, B is the opening of the aortic valve. So until we open that valve up, we have a closed chamber here that we're squeezing down on, building pressure until we get to the point where the pressure in the left ventricle is greater than the pressure in the aorta, and we pop open that aortic valve and we have the ejection phase. And then we get to C here, which is the closure of the aortic valve. And so this is, again, looking at that pressure gradient between left ventricle and the aorta. The pressure in the aorta is becoming greater than the left ventricular pressure, causing this aortic valve to close again. Now we have another isovolumetric phase. This time it is isovolumetric relaxation. So again, no change in volume, but we just have a drastic reduction in pressure as the heart is relaxing out, going into the diastolic phase. And then again, the opening of that mitral valve. And so what kind of information can we gain from the pressure volume loop? We can gain a ton of hemodynamic information. So the width of the pressure volume loop is going to be stroke volume. So we get the end systolic volume here, the end diastolic volume here. And so the difference between that is going to be our stroke volume. We can also gather information on systolic blood pressure, diastolic blood pressure, the end diastolic blood pressure, your left atrial pressure, the pressure at the end of systole. So we can gain a ton of just general pressure hemodynamic information. And as we're going to see here shortly, we can also gain a great deal of energetic information. And as I'll talk about, pressure volume loops provide us a nice behind the scenes look at what's going on in the left ventricle. So we're going to jump into the Harvey app and kind of take a look at these in real time in the simulator. So this green loop is going to represent a nice healthy heart with normal pressures, normal volumes, normal numbers on the monitor here. And then this purple loop is going to represent a general cardiogenic shock state. So as you see on the monitor, we see those classic signs of cardiogenic shock, tachycardia, hypotension. Our filling pressures are increasing, with a wedge of 25. Our CPO, or cardiac power output, so here's that power aspect kind of in the clinical realm, that is less than 0.6. That's that kind of cutoff, so we are far below that. Cardiac output is reduced. Our SVO2 is down. So looking at the pressure volume loop itself, we see a much smaller loop that's moved up and to the right here. So that's going to become significant as we kind of move along in our conversation here of energetics. And so another aspect of before we jump into those energetics, another aspect of the pressure volume loop that we need to discuss is the end systolic pressure volume relationship, which will be this straight linear line here, and the end diastolic pressure volume relationship, which is this curved kind of curvilinear line that we have at the bottom here. So going back to the end-systolic pressure-volume relationship, again, it's linear. It's the slope of this line is going to tell us our end-systolic elastance, and that's going to be a direct indicator of contractility, a direct measurement of contractility. And so the steeper this slope is, the greater our contractility is. So if this line moves to the left, contractility is increased. If it goes down and the slope is more shallow, like in the case of our cardiogenic shock heart, contractility is reduced. And so next, we want to look at the energetic side of measurements of stroke work and potential energy. So the area within this pressure volume loop is going to be the stroke work. And that's going to be that energy that's externally transferred to the system. And so again, it's entirely the area in this loop. So you can see in the green loop, it's much larger, whereas in the purple loop, we have much smaller stroke work. The next side of that equation for our total work done is going to be stroke work plus potential energy. And the potential energy is going to be bound by this end systolic pressure volume relationship and end diastolic pressure volume relationship. And so that's going to be the area within this region here. And sorry, I forgot to mention, so the importance of the end diastolic pressure volume relationship is it gives us an indication of compliance. So as we're moving up into the right here, we're becoming less compliant. We're becoming in a much more loaded condition. So stepping back into the energetic conversation of stroke work in here, potential energy here. So what we think about with this energetics is the efficiency of the heart. So we want a greater proportion of this ratio to be stroke work, whereas in our healthy heart, you see there's a much larger area here compared to our small area here. When we move to the purple loop, the ratio has changed drastically with a much greater proportion shifting to this potential energy. And again, the potential energy is that energy used during contraction, relaxation, that's not externally transferred to the systems. The system being our end organs, the circulatory system, our end organs. So if we're not externally transferring that energy, it's kind of wasted energy, and we have a very inefficient heart in the purple here, purple cardiogenic shock heart compared to our green healthy heart. Now, when we think about the kind of physiological cascade of cardiogenic shock, we have this initial phase, and then we also have this neurohormonal response. That's going to be, frankly, it's a bit counterproductive as we increase the afterload on this already compromised and failing heart. Yes, it's going to increase our blood pressure, as you saw a little bit here. Our blood pressure went up a little bit, and that's going to be kind of a theme, especially as next we're going to talk about adding in ECMO and what that's going to do for our afterload sensitivity and for some of these numbers on the monitor. So this brings us to a big point of our discussion of we have the two kind of goals here in treating cardiogenic shock. We have increasing systemic perfusion, but we also want to think about cardioprotection. What are we going to do once we get VA ECMO off? Are we going to have a heart to fall back on? Are we going to have a healthy heart? Are we going to have a heart that's then the patient that has chronic heart failure? Or are we going to try and establish as much myocardial recovery as we can and get that patient to a healthy living status with a greater quality of life? So that neurohormonal response maybe increases our blood pressure a little bit, but the big point I want to make here with that neurohormonal response is that, again, it's increasing afterload. And in this orange loop now, we see that the afterload sensitivity becoming apparent because we're moving up and to the right, so we're becoming more loaded as that left ventricle is less able to eject the blood out against that greater afterload pressure, or that greater afterload resistance. And we also see our end systolic volume. So the closure of that aortic valve occurs here. So as that resistance becomes greater and greater, that aortic valve is going to close earlier. We're going to have a higher end systolic volume, and we're going to have a smaller stroke volume. So as we kind of look at this concept of afterload sensitivity, it becomes apparent here with this neurohormonal response. But as we add ECMO into the picture, we can really see this becoming apparent. And again, we want to keep in mind that continuum of severity of cardiogenic shock, and that not every patient that gets peripheral VA ECMO is going to have this profound left ventricular distension, but every patient is at risk for it, and it's something we need to have in the back of our mind. We need to be thinking about it up front, as the optimal time for treating that is going to be within those first couple hours. As we want, again, to establish myocardial recovery, be thinking about that cardioprotection aspect. So thinking about the systemic perfusion versus cardioprotection. As we add ECMO, we look at our monitor here and we think we have improved, yay, which is very true. We've increased our blood pressure, we've increased our cardiac power output, we've increased our oxygenation, and even increased our total cardiac output some. But what have we also done? We've increased our filling pressures, our wedge pressures drastically up, and then again, the pressure volume loop gives us that behind the scenes. So looking at the pressure volume loop here, we can see we're failing in the cardioprotection aspect right now. We have no ejection going on right now. The aortic valve is not opening at all. We have the stroke work, so that external energy to the system is zero right now. We are all potential energy, an extremely inefficient heart. So all of that myocardial work is being done for no reason, and we're just likely increasing our infarct zone, causing remodeling damages, again, kind of on that pathway to a chronic heart failure state. So how do we combat this? There's kind of two main ways that we're going to talk about here. So we have venting and we have unloading. So first, we're going to look at LV venting. And so this example is just tying in a direct LV vent into the left ventricle that's then tied back into the ECMO circuit. And so as you see here, we are moving the ECMO turquoise loop, or lack of a loop, but the line here is very loaded. It's up this end-diastolic pressure-volume relationship, up and to the right. What venting does is moves us back down into the left, reducing that loading state on the left ventricle, reducing that LV distension. And the mechanism for doing that is it's reducing the volume. It's like putting a straw in there that's just passively releasing that volume and tying it back into the ECMO circuit. So we see a lot of great improvement on our monitor with those wedge pressures coming down, SpO2 going up, I believe a little bit of an increase in our cardiac output and our CPO. So a great method of reducing LV distension. But what we want to think about is another method of reducing that LV distension. And that's going to be with a percutaneous ventricular assist device such as the Impella. So we're going to remove this vent and we're going to go in and add an Impella device. And so you're going to see a very similar response as to when we initiated that LV vent. So we go from the turquoise line that's ECMO, and we move down into the left on that end diastolic pressure volume relationship. We're going from that extremely loaded state. Now we are unloading. So with Impella, we also get that volume unloading. But what we want to think about here is that with the Impella, we have active forward flow unloading, which means we're now contributing more output to the system. We're increasing our hemodynamic stability, increasing that systemic perfusion side of the things. So the Impella is not only focusing on that cardioprotection, but it's also helping with the systemic perfusion side of things. And so this is with the RPMs all the way up. Even if we take it down to a more realistic, P2 to P4 level, we still get a significant amount of reduction in that loading condition. And what we also get is with that increased hemodynamic stability, we now have the opportunity to introduce other therapies to combat some of these things like our tachycardia, that high systemic vascular resistance. If we likely have on several pressors, we can start coming down on our pressors, as we know that the more pressors we have in these patients, the higher risk of mortality. And the more pressures we have on, the more clamped on peripheral vascularly they're going to be, and the less likely they're going to be able to use that oxygen uptake that we're working so hard to provide them. So with the Impella, we can look at, then we would be able to combat this heart rate. The specifics of this is beyond the scope of this discussion. This is more of, again, just a conceptual exercise here. So as we reduce the heart rate, we see further improvements all throughout our monitor. And then if we, simulate reducing vasopressors, potentially even, putting on vasodilators, if able to, we see even further drastic improvements on our monitor and on our pressure volume loop. And so takeaways here, we want to think about cardioprotection along with that systemic perfusion aspect. So VA ECMO does a fantastic job of providing that systemic perfusion aspect. And in patients without the greater severity of cardiogenic shock, without that extreme afterload sensitivity, maybe they're able to, the volume reduction, removing it from the venous side, maybe that's able to kind of allow the heart to rest a bit. But when we get into this state of extreme afterload sensitivity and LV distension, we need to be thinking about early and often LV distension, cardioprotection, along with that systemic perfusion side of the equation. And so again, with afterload sensitivity, every pump we talk about, so ECMO, Impella, we always talk about being preload dependent and afterload sensitive. So what other pump is also preload dependent and afterload sensitive? That's going to be our native heart. This becomes very apparent in this conversation here. So we have to have preload. That's not exactly what we're discussing here, but we have that afterload sensitivity side of things. So just keeping that in mind as we're increasing therapies such as VA ECMO. And so discussion from here, this is also a little bit beyond the scope of this conversation, but how do we identify these patients, the best practices in identifying them early and often. Like we discussed, there's that 2-hour window that's really ideal for establishing this unloading. But thank you for this time, and I look forward to answering any questions you may have. So thank you. So thank you all again for this opportunity to present. And if anybody has any questions, feel free to send it in the chat here or get on and ask, or you can always send me an email as well. So we have a question about using Impella to help wean. So yeah, I mean, that's going to be it can be used several different ways. I mean, different institutes may wean Impella first, and others may wean ECMO first. I feel like it's kind of a unique thing to the current situation of how much ECMO flow do you need, what's the oxygenation requirement. So if you can get past those oxygenation requirements, in my opinion, reducing the VA ECMO side of things and weaning to an Impella is going to be more in line with the cardioprotection side of things. So another question about recommending the timing for deploying an LV vent. So I think the best approach is just having a plan up front. Anytime you're going on VA ECMO, how are you going to determine if this patient does have LV distension? And there's a lot of evidence out there that shows, in the first 2 hours, that you have a kind of a 2-hour window there, that if you can treat the LV distension, if you can treat with a vent or an unloading within 2 hours from the time of VA ECMO, the outcomes of mortality and weaning from ventilators are improved. So if I think it's hard to put an exact number outside of that 2-hour window, but I think the important thing is having PA catheters, doing frequent echoes. How are you determining if this patient does have LV distension? And if they do, treating it in a timely manner. Some institutes may be a little more aggressive and just upfront when they put on VA ECMO, just go ahead and put in an Impella as well. So that maybe based on the pre-ECMO echo, maybe that can be a strategy that could be kept in mind. But I think frequent assessments of pulsatility, of the smoke in the echo views, and your PA numbers, and your ventilator, your oxygenation issues that you may have if you do have the kind of pulmonary edema issues from the backing up, are all things to keep in mind. So I've got another question about asking about weaning chemical support and allowing MCS to do the work. And especially if it's all going to be dependent in this scenario with this simulator, the pressures were great and whatnot. It's going to be dependent on a real patient scenario, but if you can wean down chemical support, that's going to be fantastic for the systemic perfusion side of things. So you can kind of not be so clamped down peripherally, but also for that cardioprotection aspect. The higher the heart rate is from the vasopressors and inotropes, the greater myocardial oxygen consumption is going to be. And for inotropes, asking more from that compromised heart to squeeze harder is also going to increase myocardial oxygen consumption. And if we have a weak and failing heart because of, for say, an acute MI, then that infarct zone is likely being stressed out even further. We have an issue of getting oxygen to the tissue, to the myocardial tissue, and as we are putting excess afterload and asking it to squeeze harder, we're just increasing that oxygen consumption. So yes, I would say it's best to assess your patient. What are the pressures? How are they perfusing? But if you can get down on that chemical support, then it's the best for systemic perfusion and for cardioprotection.